Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell & Eleanor Blum Patient and Family Learning Center at Mass General. Before I get started, just want to go over a few items with you all. Please note that this session is being recorded for educational purposes. If you're interested in viewing the recording, it'll be made available on the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has muted so we can hear our guest speakers today. If you have any questions for our guest speakers, you may use the chat feature, which is located at the bottom of your screen. We'll have time for in the end. Only Blum Center staff and our guest speakers will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we would like to ask you to help us complete. Your feedback is important to us as we plan future programs. Okay, so next I would like to introduce you all today's guest speakers. Joining us today, we have Dr. Lecia Sequist. Dr. Sequist is the Landry Family Professor of Medicine at Harvard Medical School and the Director of the Cancer Early Detection and Diagnostics Program at Mass General Cancer Center. Her research focuses on novel strategies to improve lung cancer detection, including AI and blood-based biomarkers. Joining us today, we also have Dr. Allison Chang. Dr. Chang is a graduate of Harvard Medical School and has a PhD in neuroscience. She is currently a medical oncology fellow in the Joint Mass General Dana-Farber program and a research fellow studying lung cancer and early detection. They join us today to give a talk on lung cancer screening. So please join me in welcoming them.
Thank you, Amy. Thank you for having us. And thank you guys for joining. I hope that you learn a lot today. Dr. Chang is going to be giving the presentation, and she's excellent. You're really going to enjoy it. And what I hope happens after today is that you can take what you've learned and share it with your family and friends, because not enough people know about lung cancer screening. So thank you for taking the first step, which is learning more today. And please don't forget to take the second step, which is tell someone else what you learned. All right, Dr. Chang.
Thank you, Lecia, and thank you, Amy. So as Dr. Sequist said, today we'll be talking about lung cancer screening, what you don't know about this screening but should. And like Dr. Sequist said, this is an area of active growth and an area where each one of you can have a big impact. And I hope by the end of this talk, you have a better sense of why exactly that is. These are Dr. Sequist's disclosures. And then here are two women who appear to be undergoing treatment for cancer. And I think if most of us saw these images out in the world, we would assume that they have breast cancer. But in actuality, the leading cause of cancer-related death among both men and women is lung cancer. And for the top two to three causes of leading causes of cancer-related death, we do have screening programs that is recommended by the US PSTF. It's likely something that you've all discussed in your primary care appointments. For men, the question of prostate cancer screening is currently controversial, but is something that we are also actively researching. But again, for women, lung cancer is the leading cause of death. So why are people dying at such high rates from lung cancer? Yes, it's a difficult disease to treat, but we've developed so many new treatments, especially over the last 20 years. And you may have heard terms like targeted therapy or immunotherapy or taking a pill to treat your cancer instead of going in for chemotherapy infusions. And in many cases, people are referencing medications that were pioneered and made standard of care in lung cancer. So why is it still so deadly if we're getting so much better at treating it? The main problem is that we are diagnosing lung cancer too late. It is simply too late by the time we first see patients in clinic. Almost half of patients at the time that they are diagnosed with lung cancer already have distant metastases. And what metastases are deposits of lung cancer that have migrated far away from where they originated in the lung and taken up shop elsewhere. And another term for this is stage 4 disease, which I think more people are familiar with. And there are, of course, other stages of cancer that are roughly broken down here, not by stage, but by where the cancer is located. So localized disease is when the cancer is restricted to the lung. We are diagnosing patients with localized disease about a quarter of the time, which is simply not enough. And then for regional metastases, this is where things have started to get outside the lung, but are still in the general area, whether it's in a lymph node or some other part of the lung that is nearby where it started. And localized disease and regional disease are considered curable. But unfortunately, once a cancer has gotten far from where it started, it is no longer considered curable. And this is where we are missing the time to intervene. If we look at 5-year survival for each stage of lung cancer, we can see that overall, about 25% of lung cancer patients who were diagnosed between 2013 and 2019 were still alive 5 years after their diagnosis. For localized disease, so disease that is still in one spot of the lung, more than half of patients had not died 5 years after the time of diagnosis. And if we break this down further, which I'm not showing here, teeny tiny bits of lung cancer that we catch very early, so a stage 1A or a stage 1B, we're doing much, much better than 58% 5-year survival. It's upwards of 80, 90%. But if you look at the distant patients who are presenting with distant metastases at the time of diagnosis, less than 10% are alive 5 years later. So we have to do a better job of catching lung cancer before it spreads. But how do we do this? And this is where we get into early detection. So if we look at a person's lung cancer journey, we have the time the disease starts, which we're often unaware of. And then this period of time that we could refer to as the preclinical phase, where there is a window between disease onset and symptom onset, where the patient might not know the cancer is there, but it's still growing. And then, of course, once the symptoms begin, this is generally when patients present to healthcare, get a diagnosis, and then ultimately, for especially patients who present with distant metastatic disease, leads to their death. And so this window, we're very interested in this window where the disease is still curable and doesn't present with symptoms. And this is what we call screening. We're testing someone who feels well, no symptoms, to see if anything is there. So you've likely heard of other types of cancer screening. We mentioned some of them earlier. The 3 main types of cancer screening that we do routinely are breast cancer screening, cervical cancer screening, and colon cancer screening. And we're generally doing a pretty good job of this. The uptake for eligible patients is significant, way upwards of 50%. And for cervical cancer screening, we're actually getting close to 90%. So how do you screen for lung cancer? It doesn't require any preparation. There's no fasting. Nothing gets poked in you. Nothing is invasive about this. Instead, you go into a CT scanner or a CAT scan, and you get a very, very low dose of radiation. It's essentially like an X-ray that scans through 3-dimensionally instead of 2-dimensionally. And I will attempt to show this video.
Welcome to Mass General Brigham.
Are you seeing the video?
We look forward to guiding you through your
No,
visit.
we don't.
Glad you chose us.
Yeah, there now we are.
Great.
When you check in, we'll have you fill out some brief paperwork and may ask for a photo ID. We may ask you to repeat your information for your safety. We'll give you an ID bracelet and have you change into hospital attire. A lung screening CT takes detailed images of the lungs to screen for lung cancer. It can find cancer early when it's most treatable. The exam takes about 15 minutes. When it is time for your test, a technologist will bring you into the exam room and position you on the table. Technologists are specifically trained to guide you through your exam. You can talk to your technologist at any time. They may ask you to lie still and hold your breath periodically to help get clearer images. Technologists don't interpret images, so they can't tell you the results. After your exam, a radiologist reports what they see on your scans to your referring doctor. Your results will be available in Patient Gateway in about a week. Let us know if you have any questions. Your privacy and comfort are important to us. We look forward to welcoming you to Mass General Brigham.
Let me see if I can navigate back elegantly. Can everyone see the presentation again?
Yes.
Great. And I will say that most people who get their first lung cancer screening CT scan come out saying, wow, that was so easy. So I think that, although it does involve a large scanner, it's fairly quick and painless. But even still, we are doing a very poor job of lung cancer screening. So I showed you the screening rates for breast cancer, cervical cancer, and colon cancer, which are well upwards of 50%. And across the United States, we are only screening 5% of patients who are eligible for lung cancer. And we should give ourselves a pat on the back because we are in the lead in Massachusetts, screening a whopping 16% of eligible individuals. But I will assume that we are all displeased with how low this number still is. And if you look towards the far left of this bar graph, there are other states that are down to about 1% of eligible patients getting screened. So this is simply not enough. So why aren't we getting screened for lung cancer? There are a whole slew of reasons why patients are not getting screened for lung cancer. Some, I think, resulting in more of a barrier in parts of the country than others, but we can generally break it down into lack of awareness. These are cancer screening guidelines that are relatively recent. The first ones were issued in 2013, and then they were changed again in 2021. There's unfamiliarity with the guidelines, which I think goes along with the newness and the fact that it keeps getting changed. There are challenges to accessing CT scanners. Not every hospital has many CT scanners, and certainly areas in rural United States are not going to have an easily accessible CT scanner. Cost concerns, this is still not universally covered by Medicaid. There's skepticism regarding the evidence. There are fears about getting screened for lung cancer, and I think most importantly, a stigma against screening for lung cancer because it's been inextricably linked with smoking over the years. It's hard to identify eligible patients, and I'll go a little bit more into this, but for the other types of lung cancer, for other types of cancer screening, there's simply an age cutoff. But for lung cancer screening, it's age combined with the number of years you smoked, the number of packs per day you smoked, and also the years since quitting smoking, which is actually a lot of information to have to identify about each patient, especially for a busy primary care doctor. And then there's difficulty with managing abnormal results because lung nodules and lung abnormalities in general come in all shapes and sizes, and it often takes a team of specialists, both in surgery, radiation oncology, and medical oncology, like myself and Dr. Sequist, to actually know what to do with these findings. But I want to linger on the stigma part of this because I think many of these other challenges actually come from the fact that this stigma exists. And I think that whenever there is such a powerful link with between two policies, not policies, whenever there's such a powerful link between two things, we have to assume that it is affecting a lot of the policies surrounding it. So the campaign against smoking has been extremely important, and no doubt smoking is a major cause of lung cancer, but this has also resulted in a powerful stigma against lung cancer. Often when Dr. Sequist and I see patients with a new diagnosis of lung cancer, they have a lot of fear about the cancer itself, but this is overshadowed by deep feelings of guilt that they brought this upon themselves. And so this likely bleeds into a lot of our policies surrounding lung cancer screening. So I'll compare the screening guidelines between mammograms for breast cancer and then lung cancer. And this gets at the complexities involved in the two. So for a mammogram, there is an age cutoff, and there are simple guidelines that are contained entirely on this one slide about payment for this. and when the scan is indicated. But for lung cancer, it goes on. And I won't read this entire thing, but I will show you that there are 1, 2, 3, 4 slides of information about who gets screened, when it's covered, and what these different terms mean. And so this creates a maze that is a big barrier to screening. And as mentioned earlier, access to CT scanners is also problematic. This is a map showing states in different colors based on access to screening and mortality from lung cancer. And you can see that this is not uniform across the United States. And what's worse is that access is worst in areas of the country that need it most. So I'll direct your attention to the states colored in green, where access to lung cancer screening is low, but mortality from lung cancer is high. And these states are in green partly because they chose not to expand Medicare, which made it more difficult to get reimbursed for these low-dose CT scans. But despite the strong link between smoking and lung cancer, smoking isn't the whole story. And this is scary for people. And I'll go into these data in a minute. But it's easier to blame lung cancer on smoking. We feel less vulnerable. We feel more in control. We think to ourselves, oh, if I don't smoke, I won't get lung cancer. But unfortunately, that's not true. And we're learning more and more about this as the overall prevalence of smoking declines. You may have seen some statistics that smoking is associated with 80% of lung cancer cases, but this doesn't necessarily say that smoking was the cause of 80% of lung cancer, because someone may have smoked for some period of time, but get a type of lung cancer that is not related to smoking. And now we're understanding that these types of non-smoking related lung cancers have a unique biology and require a distinct treatment approach. And a lot of these lung cancers occur in Asian countries and in patients of Asian descent. So I'll direct your attention to the bottom part of this graph, where we have Singapore, China, and Taiwan. And what's shown here is the smoking prevalence among patients who are diagnosed with lung cancer. And the orange is male and the blue is female. And you can see that for China and Taiwan, less than 10% of patients diagnosed with lung cancer actually have smoked. And so clearly there is a significant portion of lung cancer that has nothing to do with smoking whatsoever. So who is at risk for lung cancer? I wish I had an answer to this question. It is very complex and is an active area of research, but there are many different risk factors, including air pollution, secondhand smoke, radon exposure, and then occupational exposures, whether that's fumes within a factory or burn pits if you were deployed in Iraq. And all of these risk factors undoubtedly interact with your heritage, your genes that you were born with, and whether you have a family history of lung cancer. So we're trying to learn more about this and also learn how to actually identify these patients who do not smoke or have a very light history of smoking, but who nonetheless are at risk for lung cancer. And so Dr. Sequist has been a pioneer in this area of using new technology to create new approaches to identify patients who are at risk for lung cancer. And I'll go over one such form of this new technology and touch briefly upon some others. So this was a collaboration with computational scientists at MIT to design a machine learning algorithm that analyzes low-dose CTs like the ones we obtain for lung cancer screening. And the challenge was to take a single CT and by looking at that, assess a person's future risk for lung cancer. So this is not looking at the scan and trying to find cancer in that scan. This is trying to look at the lungs and assess the person's personalized risk score for developing lung cancer over the next 6 years. So we take the entire low-dose CT and put it through this machine learning algorithm. And what you get out is a graph like the one that you see here in blue, where there is a personalized curve representing the cumulative risk of getting lung cancer over the next 6 years. And I won't go into these curves. These are called ROC curves. But this is just to show that it's a measure of how a medical test performs. And the more it's positioned towards the top left, the better it is. And what an ROC curve does is it basically tries to distinguish between two different diagnoses, either likely to develop cancer or not likely to develop cancer. If the curve lies on that dotted line, that means that it's performing no better than chance. We might as well flip a coin. But you can see here that these curves are far from the dotted line and very close to the top left, which means that the model is doing a very good job of identifying patients who are at risk for lung cancer. The most common question we get is, what is Sybil looking at? And I should have mentioned explicitly, but Sybil is the name of our model. And we don't know. This is unfortunately the way that much of artificial intelligence works, where you give the computer a vast amount of data and the computer is able to rapidly assess it and pull out patterns. And this is amazing because it results in models that can identify patterns that are not immediately apparent to even highly skilled radiologists. And so the machine can help us identify information that we would otherwise be unaware of. But again, we don't exactly know what that is in this case. So we can ask the machine to tell us a little bit more about what it's looking at. This is a scan obtained from a patient who was part of the NLST, or the National Lung Screening Trial, which was a trial about a decade ago that helped establish the screening guidelines in the first place and establish the benefit of lung cancer screening. This was a 69-year-old man with a 99 pack year smoking history. So that means that this patient smoked for a long period of time and smoked quite a few cigarettes during that period of time. And the baseline scan was read by the radiologist as negative screen, minor abnormalities, not suspicious for lung cancer. But when Sybil looked at the scan, Sybil placed this patient in the 75th risk percentile over the next 6 years. And so when you ask Sybil to say, where in the scan are you getting this, this information from, Sybil is able to create an attention map. This is not a PET scan for those of you who are familiar with a PET scan, but the red here shows where in the image most of the information is coming from to influence this prediction. And the following year, a worrisome nodule appeared in the location that Sybil was focused on for risk assessment, which was quite remarkable. And the patient had surgery for what was a 2.2 centimeter poorly differentiated squamous cell lung cancer. And this is stage 1 lung cancer, and this is cured with surgery. Another potential benefit of a risk stratification model like Sybil is that you could imagine in the future being able to generate personalized risk scores for each patient and then a personalized screening schedule for that patient. So the patient in blue might have a higher risk score and therefore return once a year or even twice a year because we're worried about that patient. Whereas the patient in yellow might have a very low risk score, and so we get scans less frequently. But overall, we have a couple areas to work on to improve our approach to lung cancer screening and catch these lung cancers earlier. And we like to refer to this as both the grasp and the reach of lung cancer screening. So the first bar graph on the left is approximately the number of patients who actually get lung cancer. And the second bar graph shows the portion of those patients with lung cancer who would have been eligible for screening. And so it's less than half, which is, again, quite remarkable and goes back to that plot that I showed earlier, where for some patient populations, very few patients with lung cancer actually have any smoking history. Because right now, our lung cancer screening guidelines are solely based on age and smoking exposure. So we have to improve our reach of our eligibility guidelines to capture more patients who are at risk for developing lung cancer. And then if we look at the third bar, we see the proportion of patients who actually participated in lung cancer screening. And if you recall to one of the plots I showed much earlier in the talk, nationally, we are only getting 5% of eligible patients to actually get screening. And then among those patients, we have even fewer who are actually coming back for regular screening. Right now, these low-dose lung cancer screening scans are intended to be applied annually to those patients who qualify. So many patients come in for a scan and then they just don't come back in the future. So we have to improve our grasp or how to reach and then keep these at-risk patients in the lung cancer screening program. So what are we doing to help make this happen? At MGH, we have a clinical pathway as part of a new dedicated clinic that is specifically designed for cancer early detection and diagnostics. And our mission is to decrease cancer morbidity and mortality by designing, testing, and implementing early cancer detection. So we offer 3 general categories of appointments. One is a cancer risk assessment, where you come and we go over all of your medical history and your family history, and we discuss with you what your personal cancer risk is based on your family history, your comorbidities, occupational exposures, and anything else that we think could constitute an increased risk for cancer. And then we go over what our recommendations are for the type and frequency of screening that you should get, as well as new screening that is available. So I talked about SIBIL as one new type of cancer screening, but there are also new blood-based tests where with a simple blood draw, you can actually assess whether or not you are likely to have cancer at a given moment. And the benefit of this is obviously that generally giving blood is easy. And also it tests for the likelihood that you have cancer across dozens of different types of cancers. And there are still other types of blood tests that are in development that will test for the presence or absence of one type of cancer. And our clinic is very active in talking to companies about their new tools and then designing clinical trials so that we can sort out how to actually use these responsibly to the benefit of our patients. And so it may be that you show up and we think that there is a clinical trial that you would qualify for to access some of these novel cancer screening tests. We also see patients who already have findings concerning for cancer, whether these are symptoms or findings on a scan that you got for other reasons. And we streamline and expedite the workup for these abnormalities. And last, the pulmonary nodule clinic, which has been in existence at MGH for a decade, has now become part of our early detection clinic, where patients who are either part of the lung cancer screening program or have gotten screens or scans for other reasons, who then have concerning pulmonary nodules, are able to come to our clinic. We have a whole team of people who are all specialists in the lungs, but with a different lens, a different subspecialty. So we have surgeons, we have interventional radiologists, interventional pulmonologists, medical oncologists, and we combine our expertise to assess each lung nodule and come up with a personalized monitoring plan or potentially a plan for biopsy if we think that that's required. And our clinic has grown rapidly. It opened just earlier this year. And so at the end of the year, we are celebrating that we have seen over 500 patients. And I will say that I suspect it is now over 600 because these data are actually about a month old. And this could not have been accomplished without a massive team of people who have all different backgrounds. We have research staff, we have planning and strategy staff, we have 2 APPs who are excellent oncology subspecialized nurse practitioners, as well as 5 separate oncologists, all medical oncologists who see patients now 5 days a week. And we also collaborate with radiologists. We have psychiatrists who help with the anxiety of undergoing lung cancer, not lung cancer, but all cancer screening and diagnostics, as well as specialists who help with lifestyle modifications like smoking cessation. So we are very proud of the amazing team that's come together in a short period of time. And we continue to grow so rapidly that there are now new faces that I have not even been able to add to this slide yet. So in conclusion, lung cancer is the most deadly cancer, in large part because we catch it too late after it has already spread. We do have effective lung cancer screening methods but very few eligible patients are actually getting screened. 16% of eligible patients are being screened in Massachusetts and only 5% nationally. And we're only screening individuals who smoked heavily, but more than half of our patients with lung cancer smoked lightly or never at all. So what are we doing about this? We're building new screening tools. We are engaging in activism to spread awareness of lung cancer screening and combat the stigma that exists against lung cancer. And I mentioned the ALCSI here. It's the American Lung Cancer Screening Initiative, which is an amazing group that is mostly run by undergraduates that actually goes out into the community and actively tries to educate patients about lung cancer. We are also enrolling at-risk patients in clinical trials. For example, 2 trials that are open or are about to open through our clinic. One is doing low-dose CT scans for Black women with any smoking history. So again, not meeting the threshold for the current guideline recommended lung cancer screening. And then also Asian women who have no smoking history. And so we look forward to being able to present these findings in the coming years. So what can you do? Talk to your friends. 5% is not a high number. 16% is not a high number. By spreading awareness, by combating the stigma against lung cancer, we can hopefully normalize lung cancer screening and start screening many more individuals. And this will result in saved lives. So thank you for your attention. I hope that you feel free to ask questions to engage in conversation about this today. Thank you.
Thank you so much, Dr. Chang. We are now at the end of the session. If you have any questions, feel free to enter them in the chat. We have a question regarding the program. Can patients self-refer themselves to your program?
I have a clarifying question. Is that about the early detection program or a lung cancer screening program? I guess I'll answer both. The answer is yes for both. Dr. Sequist just put the phone number in the chat, but we have plenty of patients who self-refer to our early detection clinic. And also, if you feel that you qualify for lung cancer screening, you can either reach out to us directly through the early detection clinic or talk to your PCP, who can also put you in for a low-dose CT. And I will say, I will deny that I said this, but if you feel like you had sort of a borderline smoking history, so you can calculate whether or not you meet the criteria for the current standard of care lung cancer screening by multiplying the number of years you smoked by the number of packs per day you smoked. So for example, if you smoked about half a pack a day for 40 years, that would be 20 pack years. And that does meet the threshold for current lung cancer screening. There in the USPSTF is currently a stipulation that you do not qualify if you quit 15 years ago or more. But just last month, the American Cancer Society issued a recommendation that we should get rid of that. And that's based on data that even for 20, 25, 30 years, if you have a history of smoking, it does increase your risk of lung cancer. And so we have actually seen patients with abnormalities in their lungs who saw that the American Cancer Society issued this recommendation, and they said, oh my gosh, now I qualify, reached out to their PCPs and got a scan. So I encourage all of you to think carefully about your own smoking exposure, your loved one's smoking exposure, and whether or not they qualify.
Do you know if the conversation about screening is part of, a conversation between their primary care physicians and patients, whether, to get screened or assessing their risk for lung cancer? Like, for instance, you just mentioned, their smoking history.
It's a great question, and it gets at the complexity of this type of screening. So for colonoscopy, once you turn 45, you qualify. There really isn't much of a conversation beyond that. But for lung cancer, it is quite nuanced, where it's the age, you need to be at least 50, and then you need to talk about these multiple different parameters and do some mental math to figure out whether or not you are able to get lung cancer screening. And so yes, this should be happening in clinic, but because of its complexity, it's often shortchanged or omitted. And again, patients, because of the stigma, would prefer not to qualify. You don't really want to say, oh, yes, I've smoked heavily. And I'll give a personal example of this where my mother's boyfriend constantly downplays the amount of smoking that he engaged in throughout his life and said, oh, it was just a few cigarettes here and there. But then if you ask a couple more questions, which of course I do because this is my passion, he's actually been smoking a decent amount for about 40 years, where if you did the math, maybe he wouldn't qualify, but I suspect that he should qualify.
Thank you. Earlier in your slides, you had covered the Sybil technology, which is amazing. Is this available to all patients who are eligible to be screened at MGH or outside of MGH?
Dr. Sequist, do you want to take this one?
Yeah, sure. Thanks, Amy. No, Sybil is not quite ready for prime time yet, but we are engaged in doing some clinical trials to try and get the data to the point where it could be ready for prime time as soon as possible. But right now, it's not something that a patient or a physician can request to say, I'd like a lung cancer screening and I'd like Sybil run on it, because we don't have the proof that it should change the recommendation for what should be done yet. But that's what we're trying over the next 1 to 2 years to complete, is being able to be more confident in what a high Sybil score might mean for a patient.
Thank you. So while we see if there are any additional questions in the chat, do you have any final thoughts you'd like to share with the audience?
I'll just say that, you know, with the holiday season upon us, I think it's a great opportunity to talk about this with your loved ones. And I think that it's a great opportunity in particular to make this a loving conversation and not one that is judgmental, because we know from research that that is the best way to increase the likelihood that someone will actually get screened.
Thank you. And we do have a question regarding coverage. Do you know if insurance generally covers the scan?
It's another great question. I will say that for the most part, yes. There are parts of Medicaid that do not currently cover it, though, but private insurance is currently required to cover it.
And is vaping considered the same as smoking?
It's a great question. There is not enough research looking at other types of smoking. So smoking pipes, cigars, smoking marijuana, and vaping. I personally consider all of these in the category of smoking. While it's not necessarily the exact same as smoking cigarettes, it can certainly expose your lungs and the cells in your lungs to toxins that can increase the likelihood that cancer will develop. I will say that for me personally, marijuana smoking is particularly concerning because these are generally joints that you roll yourself at home, and they don't even have the filters that most cigarettes have. So I think that it's something to keep in the back of your mind if that is a behavior that either you have partaken in or something that a loved one is partaking in.
Thank you. We have a question regarding a patient who may have an appointment with the pulmonary clinic. If they have an appointment with them, can they request for an appointment with the early detection or for lung cancer screening?
Yes to both.
Yeah, I think if there are some nuanced differences of some things that pulmonary may be better to help with, for example, management of chronic lung disease or asthma, or some types of infections of the lung. But if there's any question about if a patient is going to the correct clinic, don't hesitate to give the early detection clinic a call. We have nurses that can answer questions and help figure out if our clinic is the right place for that patient. So if there's any doubt, just give us a call.
Thank you. So why don't we wait for another few seconds to see if there are any final questions in the chat. Otherwise, I think it'd be okay to end early today.
Thank you to everyone for attending. Thank you, Dr. Chang, for such a great talk.
Yeah, thank you.
So I don't think I see any additional questions. Thank you so much for your time today. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, it'll be made available on the Blum Center website at blumsmassgeneral.org/Blum-Center. Thank you so much, Dr. Chang. Thank you so much, Dr. Sequist.
Thank you for having us.
Happy holidays, everybody.